Dear chairpersons and colleagues, I'm really delighted to be here today, and thanks to Ayman Rifai proposing this particular topic. We seldom talk about bone. You will understand and realize why when I go through this presentation. Naturally, when you are giving the patient a renal transplant, it's a wonderful gift. He's going to get rid of dialysis and all the complications and will have a free life. It is not that easy. We are still facing various challenges. Looking at infections, cardiovascular morbidities, even diabetes, I think it's easy to handle. But the osteoporosis and the persistent hyperparathyroidism, together with the high possibilities of fractures, makes things a little bit difficult. Now, chronic kidney disease for a long time has been puzzling us a lot, and we understand that it is a kind of access between the bones and the vessels and the kidney, and the crosstalks are getting so much and the noise is becoming so loud. It reminds me of the players in an orchestra warming up just before the sonata. The music, the sound, I mean, goes so high just before the sonata. Will we have any kind of a melody soon? I don't know, to explain what comes first and what to do. Mario Cozzolino, who is head of the ERA editor working group for CKD-MBD, had thought a few years back to put CKD-MBD as a syndrome. Unfortunately, it didn't fulfill the requirements, and this is understood because the presentations are bizarre and they are so different from one patient to another. Yet the concept is fair enough, and maybe in the future, with another look through nutrition, inflammation, and possibly other yet to be understood endocrinal aspects and functions of the bone, maybe things can be refined. Coming to bones after transplantation, the dreaded complication naturally is fracture, which would lead to excessive hospitalization and with the added cost, and definitely it could be associated with mortality. The pathophysiology, just as much as it is complex in CKD-MBD, it is still complex, and even more because there are added factors such as immunosuppression and probably the pre-existing renal acidity, which could also develop de novo as an added factor. But immunosuppression, particularly glucocorticoids, are very serious drugs when it comes to bone. Things are changing or a little bit better when there is adoption now of programs, immunosuppressive programs without using large amounts or to get rid of steroids early, and this is proving a better effect on what's happening in the bones. Now the pathophysiology, again, I don't know what's gone wrong with the computer. The pathophysiology again is quite complex, and I don't need to disturb you with all the complexity that is present. So I just try to simplify things to get a straightforward message to take home about this particular issue. We understand with the recent data better pathophysiology, which could reflect on a better diagnostic approach and therapies. And this is a list of the possible bone diseases that are present after kidney transplantation. You can see that the persistent hyperpara is present in up to 50%, and post-transplant osteoporosis may reach 80%. Hypercalcemia, which is something we don't deal with so much when patients are on dialysis, could reach up to 50% in the first 3 months. Also, something new to the patient and new to the treating physician is hypophosphatemia rather than hyperphosphatemia, and it's quite a problem in 90% of patients, particularly in the first 4 months, and may persist over the first year. This diagram just is simplification of what's happening, just to stress the fact that glucocorticoids are rather nasty to the bone, causing excessive osteoclastic resorption. We also have very high amounts of phosphatonin, which is FGF23, that still it takes about a year to decline to be back to the level equivalent to the same CKD stage. Phosphatonin would lead to hypophosphatemia, and hypophosphatemia again is drastic to the bone, enhancing apoptosis of the osteoblast and decreasing osteoblastogenesis. Naturally, all of these things together have a very bad effect on the bone mineral density. Fractures. The fracture sites that are common at the lumbar spine and at the hip. You would like to assess fractures naturally, but if you're going to think that the FRAX algorithm, which is the fracture risk assessment score, is good for these patients, as a matter of fact, it cannot be applied because we have a mixture of bony changes, not just osteoporosis. We may have hyperdynamic bone disease, we may have a dynamic bone disease, osteomalacia, and even a mixture of all of these together. So this algorithm is based only on certain clinical criteria. They do not use imaging at all. That's why it's used a lot to assess osteoporosis in the general population. Generally speaking, the fracture risk is quite high, about 34% higher than equivalent patients on dialysis, taking the hip and the spine, even much more, about 23 folds that in the general population. Looking a bird's eye view at the situation, one could say, according to the author, that about a quarter of these patients are liable to attain a fracture within the first 5 years of transplantation. There are certain risks associated with kidney transplant, bone loss and fracture, as you can see listed here, and these are associated with osteoporosis, so much like in the general population. But we have other risk factors to acquire a fracture, such as a pre-existing history of fracture or the persistence of renal osteodystrophy. And this is another very important risk factor, which is the risk of falls. Now, when we have a lot of diabetic patients requiring dialysis, naturally they will also be the pool for transplantation. It is not uncommon for complicated diabetic patients reaching end stage to have postural instability, decreased visual acuity, peripheral vascular disease, and neuropathy. All of these things could really lead to a fall, and a fall could be associated with a fracture. So what do we have as therapies? How are we going to treat these patients or try to prevent? Unfortunately, the management again is complex, just as is the pathophysiology. We have insufficiency of the available imaging techniques, and the gold standard of diagnosis, bone biopsy, at least for us here in Egypt, I know it is quite defective. The diagnostic imaging techniques that we have is the DEXA and the HRPQCT. DEXA, which is good in the general population to detect osteoporosis, really cannot discriminate between cortical and trabecular bone. And for our patients, we are not talking about the cortical bone. The pathology is always in the cortical, in the trabecular bone, the cancellous bone, and DEXA is not able to do any differentiation. However, if you have an area of low bone mineral density measured by DEXA at the hip or the femoral neck, this could be important in predicting a future fracture. The high-resolution peripheral quantitative computed tomography seems to be more sensitive. As you can see from the photomicrograph, you can see the cancellous bone or the trabecular bone quite clear. But again, this technique is very expensive and it's not widely used, and used mainly nowadays for research. Not only this, you can apply this testing or imaging at the radius or at the tibia, which doesn't really have to be the same at the hip or at the lumbar area, because we understand the nature of the bony changes in transplanted patient is not the same all over the body. You would like to assess your patient by labs just like you would do the same while he was on dialysis, but there is a time plan which may be a little bit different from CKD staging. As you can see, you still need to check the serum calcium and phosphorus, PTH. Maybe you like to assess the FGF23 and the vitamin D together with the bone density. All of these things, particularly the calcium and phosphorus, should be done so frequently in the first couple of months. Considerations related to immunosuppression, and on top of the list, the glucocorticoids. I'm sure everybody is aware that glucocorticoids reduce intestinal calcium absorption and increase calcium excretion, which may actually lead to some stone formation, and it does inhibit the bone formation by reducing the osteoblastic proliferation. Very serious drug when it comes to bone. Even CNIs are linked to osteoporosis. Not only this, but just like glucocorticoids, they have been also linked to osteonecrosis affecting the femoral neck. They crystallize in the tissues of the bone at that area and lead to vascular necrosis. The good news is the PSIs, the sirolimus and everolimus, show some beneficial effects regarding osteoblastic proliferation, and they decrease the osteoclastic mediated bone resorption as well, so we don't have any negative effects related to the PSIs. Treatment, you can see the list that I'm going to talk about, and let me start just by the last point, which is the parathyroidectomy. I guess it's much better to treat parathyroidectomy if you need it for a patient with tertiary hyperparathyroidism before he's transplanted. I'm sure none of us wants to have his transplanted patient with a new graft and all the challenges to face such a surgery with a bone-hungry disease and the possibilities of infections. But there are cases that may develop tertiary hyperparathyroidism de novo after transplantation. Then you are faced with doing the surgery at that time. Phosphorus. We've been always anxious about hyperphosphatemia in our dialysis patients. Now I'm talking about hypophosphatemia. How is this happening? You have to realize that FGF23 is still very high, and FGF23 binding to clotho and the distal convoluted tubules is wasting phosphorus. Now we have active tubules, functioning tubules. This is how patients could develop hypophosphatemia. Also, glucocorticoids have such an effect. Then oral supplementation is needed, but you wouldn't start to treat before the serum phosphorus reaches just a little bit lower than 2 milligrams, and don't try to increase the serum phosphorus too much because you don't know what's coming with these patients and you're not following them up that close. And don't elevate the serum phosphorus to normal, again, for fear of exacerbation of the hyperparathyroidism. You may allow the patient to liberalize the intake of skim milk every day and other dairy products. That's something easy to control, and it would help to replenish the body with what is needed of phosphorus. All patients are supposedly taking calcium and cholecalciferol, all patients who are transplanted, but you should consider checking the serum calcium for the possible occurrence of hypercalcemia in these patients. And don't forget that the FGF23 still takes a very long time to normalize, and we really don't know what is it doing beside hypophosphatemia. Now, cinacalcet is a wonderful drug, calcium sensing receptor. We've been using it for many years with very good results in managing secondary hyperparathyroidism. It is not advised, because we do not have a randomized control trial, to use cinacalcet even if you're going to give it day after day, because there is a possibility it may lead to hypercalciuria, and even there are reports related to nephrocalcinosis when this drug is used. Cinacalcet, you should also realize it may reduce the tacrolimus concentrations if they are given together. Individualized therapy in the end is what is needed for this particular clinical situation, as much as for hypertension or diabetes, and this is what we should be considering. Teriparatide, which is the genetically engineered PTH, again has been very beneficial in treating patients with a dynamic bone disease. I came across this recent publication related to patients on dialysis taking the drug, taking the Parathyroidectomy on weekly basis, with excellent responses relating to improvement of the bone mineral density, but only at the femoral neck, while at the lumbar spine there was no significant increase. So this is for patients on dialysis. Teriparatide is a very expensive medicine, and without any background of really strong randomized control trials, we cannot recommend it for patients who are osteoporotic. But there are certain clinical situations that may imply using this drug, such as those with a dynamic bone disease, a very serious condition, as you can see the photomicrograph, with its association with vascular calcification and the calcified cardiac valves. Coming to the last group of drugs, the anti-resorptive agents or the biphosphonates, unfortunately, again, there is lack of proof. We have been using them in patients on dialysis, yes. I have to caution you that these drugs are really serious when you use them with a patient with a declining GFR, and no one expects the transplanted kidney to have a GFR of 100 or 120. And by time, maybe it even declines. You wouldn't like to use this biphosphonates except when you are really forced. So again, it is opinions and individualized therapies according to the clinical situation that you are facing. This is another recent trial that the authors used zoledronic acid, which is a biphosphonate, and they did find positive effects related to increasing the bone mineral density, but again, they recommend to use it in the worst case scenarios and not generally for all patients. The last anti-resorptive agent is the denosumab. We understand that denosumab binds to the receptor activated nuclear factor ligand, and this is important. Once it blocks its action, no more osteoblastic stimulation. Again, biannual injections of denosumab have shown in the general population some remarkable improvement in treating osteoporosis and the risk of fractures. We don't have, again, long-term trials or controlled trials to say we can use it. Yes, there has been trials to using it in patients end stage on dialysis, but unfortunately, up to now, we do not have any recommendations to use it. Again, individualized therapy when you are facing a specific clinical situation, which is rather difficult. In conclusion, dear colleagues, pre-transplantation CKD-MBD seems to be something that we have to really deal with, because it's always better to treat this condition before it gets worse. لأن طبعا بعد الترانسبلانتيشن والستيرويدز الموضوع بيتغير وبيبقى أوحش كتير. We have to consider the factors related to immune suppression, the limitations of imaging, and the caution using the various drugs. And I have to tell you that the limited studies underscoring clinical events such as fractures are making things even more difficult, and the unavailability of expert understanding of what's going on also is something to consider.